My name is Ade Adamson, and I'm an assistant professor at Medical School at the University of Texas at Austin in the United States. And today I'm going to be talking about UV and its association with skin cancer in darker skin types. First, my conflicts of interest. I'm a member of the American Academy of Dermatology's Skin of Color and Skin Cancer Work Group. Anything that I have to say today is speaking for myself, not for the American Academy of Dermatology or the work group. Skin cancer prevention in skin of color can be a challenge for two reasons. One, the incidence or the number of new cases of skin cancer is much, much lower in people with darker skin types. Two, when skin cancer develops, it's often later and the clinical outcomes are often worse. So it begs the question, how can we approach prevention in this group of individuals? This is the basic outline of my talk, where I'll define skin of color. Then we'll discuss the scope of the problem, the epidemiology of the skin cancer problem. And our focus will be on basal cell carcinoma, or BCC, squamous cell carcinoma, or BCC, and melanoma. And then the bulk of my talk will be related to prevention. Of note, basal cell and squamous cell carcinoma together are also known as non-melanoma skin cancer. Just for terminology's sake, I want to be clear. So let's talk about defining skin of color. What is skin of color? Well, it identifies individuals of racial groups that are darker than non-Hispanic whites. It's patients that not only have darker skin types, but they also have distinct hair, texture or skin practices that are unique. But what's really interesting is that their diversity makes it really hard for skin cancer messaging. And as you know, race and ethnicity, while they are related, they are not necessarily the exact same thing. Case in point, for those that identify as Hispanic or Latinx, they represent a huge variety of skin types. Another example, on the Indian subcontinent, these are two women that are of Indian descent, but the amount of melanin in their skin is vastly different. Now, cancer registries that keep track of cancer in populations don't provide granular detail about skin type. They use the blunt characteristic of race. And this can be problematic because Fitzpatrick skin type, or the melanin concentration in your skin, is directly related to your skin cancer risk. Meaning, the higher the amount of melanin you have in your skin, the lower the risk that you have of developing skin cancer. A few basic facts about skin cancer in skin of color. First is that non-Hispanic whites are over 70 times more likely to develop skin cancer. And this low incidence is likely due to increase in epidermal melanin. And there's been some studies to show that in dark skin, you can have inherent protection of SPF 15. And also, the UV dose required to produce erythema, or redness or burn, is up to 33 times greater in Black people than it is in white people. And these obviously have implications for skin cancer and skin of color. So let's move to talk about the epidemiology of these particular cancers in skin of color. Basal cell carcinoma. Usually these appear as these pink, pearly bumps on the skin that grow slowly over time, and they can ulcerate. But actually, in folks of darker skin type, they tend to be pigmented and not pink like they are in people that identify as white. The rates of basal cell carcinoma vary greatly across populations. In Black Americans, 1 to 2 per 100,000, right? Whereas in non-Hispanic white Americans, it's 1,000 plus times that rate. And these are the risk factors for BCCs. Anytime you see this many risk factors, usually that means that we actually don't know what the primary driver is of a cancer. And so, they include, scars, immunosuppression, trauma, etc. But in skin of color, as in folks that identify as white, basal cell carcinoma thankfully carries a low mortality rate. Let's talk about the other non-melanoma skin cancer, squamous cell carcinoma. The incidence here also varies greatly by racial group, with African Americans having among the lowest rates at 3 per 100,000. And again, many, many fold times more in non-Hispanic white Americans, and significantly more than in African Americans in those that identify as Asian American also have higher incidence of basal cell carcinoma, although nowhere near the amount that exists in the non-Hispanic white population. Again, a lot of suggested risk factors related to squamous cell carcinoma development in skin of color. I would say that chronic ulcers and non-healing wounds, particularly on the leg, are certainly risk factors for developing squamous cell carcinoma. Perhaps UV light, we'll get into that later on in this talk, as well as immunosuppression. See this recurring theme here, that immunosuppression increases your risk of developing cancer. Now let's talk about melanoma. This is the cancer that I study most vigorously. And this is the cancer that carries a higher mortality rate than both squamous cell and basal cell carcinoma. Here too, the incidence rates vary by racial group. 1 per 100,000 in African Americans, and up to 37 per 100,000 in non-Hispanic whites. But if you actually include melanoma in situ, that number practically doubles. So there is a 50+ fold difference in incidence between people that identify as Black versus those that identify as non-Hispanic white. And over time, in the white population, there's been a huge increase in the amount of melanoma that's been diagnosed. Thankfully, mortality has stayed relatively flat across racial groups. And incidence in folks that don't identify as white hasn't really increased tremendously. It has a bit in a few groups, but not at the rate that's seen in the non-Hispanic white population. Being a person of color is associated with a later stage of disease. And let me just show you an example here. The percentage of folks that identify as white that get a stage 1 diagnosis, it's like 76%. It's only about 50% if you identify as Black. And then if you go to stage 4, which is the latest stage of melanoma, only about 5% of folks diagnosed with melanoma that identify as white are diagnosed at this stage. It's double that if you're Black or Asian or Native American or Pacific Islander. Another way to look at it is you have a 30% less likelihood of being diagnosed at a stage 1 if you're Black, and you have a 2.5 times the likelihood of being diagnosed with stage 4 melanoma if you're Black compared to if you are white. And this translates into survival differences. Here you see a figure where the red line is represents those that identify as white. The higher you are on the line, the higher in the curve, the longer you'll survive. And then the lowest one, this black line, represents African Americans, who have the lowest survival rates of melanoma, although they don't get diagnosed with the disease as often. So I want to continue to remind you of that. Now let's talk about prevention. Probably one of the reasons why I was invited to give this talk. When you think about prevention, cancer or many diseases, as a matter of fact. You think about three kind of phases. You got primary prevention, where you focus on causal factors and controlling those. You got secondary prevention, where it generally consists of identifying and interdicting on diseases that are present in the body, but haven't progressed to a point of symptoms, dysfunction, et cetera. Screening is an example of, of an intervention there. And then there's tertiary prevention. So these are people that already have the disease, and the goal is to improve their care, reduce disability and delays in care. Basically, the receipt of high quality care. Now, I do research in all three of these phases of cancer control, but I'm not going to be talking about tertiary or secondary prevention. Let's focus on primary prevention, okay? And as I said, primary prevention aims to prevent disease or injury before it ever occurs. Now, what I don't think is necessarily up for debate is that high levels of ambient sunlight are associated with higher rates of skin cancer. That's been shown over and over and over and over again, okay? And on balance, it is true. Probably the best example of this is data from the colonial migration of folks from the UK to Australia. UK being somewhere lower sunlight, and Australia being somewhere with high levels of UV. And actually, if you look at melanoma incidence in folks in Scotland versus Queensland, Australia, which is known as the melanoma capital of the world, because it has among the highest incidence rates of melanoma on the planet, you see the difference. But this is talking about folks that are white. What I'm concerned about, right, in this talk is whether there's a relationship between UV exposure and skin cancer and people of darker skin types. So let's first focus on non-melanoma skin cancer, basal cells and squamous cell carcinomas. There are very few studies that actually look at this association. Here are a couple of the most cited ones. One by Haller et al., where they found 43 cases of squamous cell carcinoma over 40 years, and found that most of them were on non-sun exposed sites. And another institution, there were 35 cases over 5 years. And again, most cases were on non-sun exposed sites. So say, on the trunk, maybe in the groin, somewhere like that. But what I want you to note here is that in both these cases, it took many, many years to actually accrue enough cases in order to even make an analysis. So that should tell you something about just how rare this diagnosis is. If it takes 40 years to accumulate 43 cases, if you talk to your average dermatologist, they probably see 43 cases of squamous cell carcinoma within a few weeks in their practice, depending on where they practice. What about basal cell carcinomas? So there's a study by Bora et al., where again, 148 cases over 31 years, and most were found on the head and neck. There's a study done in Nigeria, only 5 cases of basal cell carcinoma over 4 years. Most were on the head and neck. But again, just because it's on the head and neck doesn't necessarily mean it was caused by UV exposure. You'd have to actually do a study or analysis that looks at people and their sun exposure habits, or where they live, and compare people with low sun exposure, high sun exposure, et cetera, et cetera. So these, but these case reports are, often cited as evidence, right? There's also evidence that shows that basal cell carcinomas are twice as high among those that are ethnically Japanese in Hawaii versus those that are Japanese in Japan, right? Which suggests, again, UVR, but again, you need to actually do a study that compares, populations and their UV exposures. What about in organ transplant recipients? Right now, I'm bringing up organ transplant recipients because they are perpetually chronically immunosuppressed. And we know that immunosuppression is a significant risk factor associated with the development of skin cancer. To my knowledge, this is the largest study looking at specifically non-white patients that have received organ transplants and what their risk of developing skin cancers are and where those skin cancers are. It included over 250 patients over an 8-year span, a decent mix of racial and ethnic categories, although only one person that identified as Pacific Islander. And as you can see here, there are very few cancers that developed in general, and even fewer still in sun-exposed sites. So you see, zeros here, not applicable, 2, 1. I mean, it's even in this population, right? It seems as though UV exposure is just, less important. So my research team and I decided to delve a little bit deeper into this subject. And we decided to look at all of the literature looking at UV exposure of all types and the risk of developing keratinocyte carcinoma, which is another name for non-melanoma skin cancer, so basal cell carcinoma, squamous cell carcinomas. And it was published in JAMA Dermatology earlier this year. 12 studies met inclusion criteria. 8 showed no association between UV exposure and keratinocyte carcinoma, but it was only UV exposure from phototherapy in these studies. 4 studies did show a positive association. The UV exposure type was geographic location or job description, and the evidence overall was low to moderate quality. Other findings that stood out from the study were that they were primarily in East Asia, and 0 studies included patients of African descent. And only 1 study included people that would be considered Hispanic, and they're Chileans. So let's talk about a few of the studies that showed a positive association. I'm showing these as studies to show that they actually were kind of inconclusive in my perspective. They weren't slam dunk cases, and then let me show you why. All right, so this study was done in Japan. The type of UV exposure was occupation. So they gave participants, or they asked participants what their jobs were, and they categorized them as working outside versus working indoors. And then they compared people in those various occupations to see if they had a higher likelihood or not of developing non-melanoma skin cancer. Outdoor workers were more likely to develop squamous cell carcinoma, but only men. There was no increase in likelihood among women, and there was no association observed for basal cell carcinomas in both sexes. In this study in Taiwan, the type of UV exposure they're looking at are lifetime sun exposure and early life sun exposure. So essentially they gave participant surveys and asked them questions around their lifetime exposure to UV, or their exposure during 15 to 24 years old, and asked them to kind of estimate it. And then they categorize some people as having high exposure versus low exposure, and they looked to see if they had an increased likelihood of squamous cell carcinoma. Interestingly, the positive association was only for squamous cell carcinoma in women for lifetime sun exposure, and it was only positive for squamous cell carcinoma in men for early life sun exposure, but not for women. So it was kind of flip-flop depending on what sex you were, which is kind of inconsistent and hard to explain. In this other study in Korea, the type of UV exposure here was based on geographic location. So as you can see here is a map, South Korea. And so they looked at your risk of developing non-melanoma skin cancer in these locations. Was it higher, closer to the equator, or not? And what they found is that, yes, there was an increased risk only for patients that were above 60 years old. Now let's talk about melanoma. One of the largest and best cited meta-analysis, which is basically an amalgamation of all the studies related to some question, right? And then they get analyzed all together, okay? And in this one, there were 57, studies published. Only 2 included Black folks, and only 1 included Hispanic folks. So it's hard to really make the case for a relationship without including darker skin types. But thankfully, there have been some studies since then. And about 18 months ago or so, my research team decided to look into the literature and see, are there studies out there that can give us more information and insight as to whether UV exposure and the risk of skin cancer, or melanoma specifically, is elevated or not. So we found 13 studies. 2 showed an association, 1 among Black men, 1 among Hispanic men. Again, all of these studies taken together were moderate to low quality. And I'm going to take you through a few of them. One study using SEER data. SEER is functionally the cancer registry of the United States. It covers a broad swath of the US, and it's often used for cancer epidemiology. And in this study, what they did is they examined the surface level of UVB in these, SEER registry locations across the country, and the incidence of melanoma in Black people over a large period of time, 20 years. No association was found between melanoma incidence and UV exposure. In this study, which used 7 cancer registries, 7 state cancer registries in the United States, authors wanted to see whether latitude and UV radiation had any impact on the development of melanoma in people that identified as white, Hispanic, and Black. What the study found was, yeah, there was a significance, but it was only among Black men. But curiously, there was no association in folks that identify as white, or folks that identified as Hispanic, or Black women, only Black men, which is the curious finding and calls into question this association. And actually, in response to this, another paper was put out using more registries. And here, the authors found that indeed there was an association between UV exposure and melanoma, but only in white people, right? Not in people that were Hispanic, Black, Native American, Asian, Pacific Islander, et cetera. Here's another study in SEER categorizing folks as low, medium, and high in terms of their UV radiation exposure. And they looked at this across many cancers, including melanoma. And of course, they found no association, none. There was another study in a multi-ethnic cohort that was conducted looking at the risk factors for melanoma in whites compared to what they called non-white multiracials, which included Latinx folks, folks that were Japanese American, Native American, and it excluded African Americans. And these were the risk factors that were not associated with melanoma, right? Now, all these risk factors, ever sunburn, lifetime sunburn, age of sunburn, family history, and people that identify as white, these are all tend to be significantly associated with your risk of melanoma. They were not in this group of folks that were not white. Here's a study out of California using their cancer registry. Early UV exposure was associated with melanoma risk in white patients, but there was no association among Hispanic patients, none. Okay, so let's talk about sunscreen, because we are at a sunscreen conference. Does sunscreen reduce melanoma risk in skin of color? Only one trial has actually, randomized control trial has actually looked at whether sunscreen can prevent melanoma. It's done in Queensland, which is where you should do it, where you would see a signal because there's so much melanoma in Queensland. The patients were randomized to discretionary use of sunscreen versus sunscreen to use every single day on their face and arms. And they were followed for 14, 15 years. Melanoma incidence was reduced by 50%. although it was not statistically significant, it's borderline. The SPF was only 15. Sunscreen application, I said, was only on face and arms, but melanoma is developed everywhere. And the absolute risk reduction was only about 1%. Anyway, this is the best evidence that we have. But pertinent to this talk, there were no dark-skinned folks in the study. I wrote about this in the Washington Post here in the US, and it was picked up by the New York Times. And then it appeared on a TV on the third hour of Today. And Today is a morning show that's pretty popular in the United States. And they brought on a dermatologist because this, blew them away that sunscreen probably does not do anything to your risk of melanoma or skin cancer if you're Black. And they brought in a dermatologist who respectfully disagreed with me, but provided no evidence and just talking points, which still frustrates me to this day. Even though, the data supporting UV exposure and skin cancer and melanoma is so poor, that hasn't stopped a bunch of research trying to examine sun protection behaviors related to skin cancer in all sorts of populations. In fact, if you look at the US Preventive Services Task Force, which is an independent volunteer panel of national experts in disease prevention and evidence-based medicine that make recommendations about various medical prevention strategies in the US population, they give a grade of B for behavioral counseling of youth for photo protection. But as I note here in red, that's only for fair skin types. It's nothing about people of color. That hasn't stopped the American Academy of Dermatology to recommend photo protection for cancer prevention in skin of color, which I think lacks evidence. Hopefully there'll be some updates to this recommendation. In summary, I would say that a significant proportion of skin cancers that occur on people with skin of color don't happen on sun exposed areas of the body. So they can't possibly be UV related. Sun protection is certainly uncertain in reducing the burden of skin cancer or outcomes related to skin cancer in folks of color. And I think educating patients that they can get cancer is something that is worthwhile. And right now, pushing UV protection as a way to prevent skin cancer in skin of color is a distraction. It's a distraction from us looking for better research into really finding what predisposing factors are. I think UV does cause a lot of different things in folks of color. Hyperpigmentation, sunburns are not great to have, and certain skin conditions might be photosensitive. So for all of these things, I think sunscreen and photo protection are important, but skin cancer prevention, skin of color is certainly not one of them. The only caveat I would say to that is that in light-skinned Asian Americans, perhaps there is a signal in squamous cell carcinoma in particular, and maybe basal cell carcinoma. And I would also say that more research needs to be done across various skin types so that we can actually have the answers that we need. And I want to end with one thing that is a pet peeve of mine, right, since I have the audience. We often talk about Bob Marley as having died from skin cancer. He died from the acral lentiginous melanoma, one of the palms and soles. But often hear his story paired with you needing to wear sunscreen in order not to get melanoma if you're Black. And this doesn't really make any logical sense because his skin cancer was on his foot, it's on his toe. And sunscreen would not have saved Bob Marley. And the other thing is that I often hear that skin cancers on the palms and the sole, or melanoma on the palms and soles, are more likely if you are of color. That is incorrect. That is patently false. The incidence, or meaning the likelihood of you developing acral melanoma, is the exact same across racial groups. The exact same. Okay. The only difference is folks that identify as white develop cancers, melanomas that are on other parts of the body at higher rates. So it appears as though they don't develop acral melanomas at the same rate. And I would like to thank all the co-authors on the papers of ours that I presented today. My mentors, Dr. Wong, for reaching out to me and inviting me to this conference, and EcoWell as well, and my funders. And I'll take questions.